after last time, we're left with a couple more of these obstetric complications. You're gonna get questions on all of these things, so definitely want to make sure you keep revising everything we're talking about. A lot of the things we talked about last time were definitely very high yield things. We also reviewed some of these ultrasounds, and now we're moving on to intrauterine growth restriction. So an EFW less than the 10th percentile for gestational age. So that's estimated fetal weight less than the 10th percentile for the gestational age. There's a lot of things that can cause intrauterine growth restriction. When you get questions on growth restriction, it's usually going to be pretty evident, as we'll see in some of these practice questions as well, that something is causing the baby to not really be able to develop. It's just not growing as big as it normally would. So right here we can see risk factors include the following: maternal systemic disease leading to uteroplacental insufficiency. Maternal substance abuse usually is going to be cocaine, which causes vasoconstriction, so not enough blood gets to the baby. Placenta previa, which we talked about in our last video. Multiple gestation, because the resources are going to be spread between the two kids, or however many pregnancies there might be at the same time. And then symmetric intrauterine growth restriction results from aneuploidy, congenital anomalies, and intrauterine infection. Asymmetric intrauterine growth restriction results from maternal hypertension or other maternal chronic disease. So whether or not the growth restriction is symmetric or asymmetric will help you kind of pick answer choices, right? Because these are all different answer choices you're going to have for what might be causing the intrauterine growth restriction. Also keep in mind that this isn't step one anymore, so they won't necessarily put these answer choices directly. They could have questions on what you would have to expect for these. So like, for example, if the question is about maternal hypertension, it doesn't necessarily mean that the maternal hypertension would be an answer choice. It might be something else that's related to maternal hypertension, something that you would find in a mom with hypertension, or of course you'll also have the differential answer choices of preeclampsia and stuff like that, which are going to be pretty irrelevant because maternal hypertension and preeclampsia present in different ways. Like preeclampsia is a big emergency, but it doesn't really cause growth restriction per se, right? So that's something to, you have to look at every single thing and find those tiny factors that would help you differentiate between one answer choice and another. Best initial test, of course, as always with pregnancy, ultrasound, right? Ultrasound to confirm gestational age and fetal weight. Confirm serial fundal height measurements with ultrasonography, and perform ultrasonography for estimated fetal weight. Umbilical artery Doppler velocimetry shows flow reversal. So this I've never really seen as per se an answer choice. I guess if flow reversal is pretty evident in a question, then you could pick to do a Doppler of the umbilical artery. But all in all, the point is to just do an ultrasound. First things first, you need to see the fetus and see how well it's growing or how well it's not growing. And then when you start seeing that the fetus isn't growing well at all, then you know something is restricting growth, because a fetus is meant to grow in size pretty vastly every single day. And once you see that the fetus isn't growing well enough, you need to consider a couple things. Maybe the gestational age that was told may have been wrong. So that's why ultrasound, as we saw way in the beginning, was the most sure shot way of knowing exactly how old a baby is. On top of that, you may also get questions on, what should you do next? Well, you should then confirm this size restriction by doing serial ultrasounds, right? So you keep checking regularly to see that, let's say excuse me, let's say you measured today and it's a certain size and you've realized that that size is small. Then you measure tomorrow and it grew appropriately, though, even though it was a small size. For that size, whatever growth rate you would expect, it actually followed. So then you would assume that maybe there's some other error, in the aging or something else. Because if growth is occurring, but you're just behind on where you were thinking the growth would be, then it's probably a wrong age question. Otherwise, if you keep doing serial fundal height measurements and serial ultrasound measurements of the baby, the growth shouldn't be there. There should be no growth, right? If it's small for gestational age, it's going to stay small for gestational age with, if anything, very minimal growth, a fraction of what you would expect in normal growth. So then they go on to say, explore the underlying etiology, correct it if possible, which would be any one of these things if you can correct them. If the patient is near due date, administer steroids, betamethasone. This is very commonly an answer choice, right? This is something you have to know, that if someone is near due date, or if someone is about to deliver early, right, for whatever reason, maybe they have contractions already, maybe they have preeclampsia, other case scenarios that we saw, premature delivery is about to happen. Betamethasone is one of the top few things you need to give so that you can get that fetal lung maturity. We're going to see other things we need to give as well to get rapid brain maturity if possible, preserve blood and coagulation if possible, and stuff like that. So we're going to see those. But right now, one at a time, we're on the betamethasone, which is like prednisone, it's a corticosteroid, and these steroids help with fetal lung maturity. Right, it requires 48 hours before delivery. So you need to start doing that, right? If you're going to be possibly delivering soon, whether it's on time or early, you still want to do this just to make sure that the fetal lung maturity is there. Perform fetal monitoring with the things we've already talked about: non-stress test, contraction stress test, right? Biophysical profile, umbilical artery Doppler velocimetry. A non-reassuring status near term means that you should deliver right away, right? A non-reassuring status was, as we said, when we do the non-stress test, if there's no decelerations, that's concerning. With the contraction stress test, there should be accelerations. If there's no accelerations with each contraction, then that's concerning. With the biophysical profile, we saw all the different things, the 5 different things that I told you guys you don't really need to memorize. The question will be telling you those 5 parameters, how much amniotic fluid index there is, fetal tones, fetal movement, stuff like that. If none of that is good, and you get 0, 2, or 4 points, then those are all signs that something is not working out. The baby is alive though, so get it out and get the baby out, because for whatever reason it's not having a good environment inside the mom. So complications are of course increased perinatal morbidity and mortality. Right? The baby may not make it. With intrauterine growth restriction, there could be a lot of things that didn't develop correctly in the baby, and the baby may not make it. So here we can see one question. We have a 36-year-old woman. Her first pregnancy, 26 weeks gestation, comes to the office for routine prenatal care. She reports good fetal movement and has no concerns. Okay, so far everything is normal. She started prenatal care at 12 weeks gestation, and an ultrasound at that time was consistent with her last menstrual period. She declined all genetic testing, which is, pretty unfortunate. Anatomy ultrasound at 19 weeks revealed an estimated fetal weight consistent with 18 weeks gestation and an ASD. So there was an ASD. She has a history of depression for which she takes citalopram. Alright. So citalopram, not necessarily a problematic medication for the fetus, but there are many anti-epileptics and antipsychotics that would not be a good idea during pregnancy. She quit smoking cigarettes prior to conception and doesn't use drugs, okay? Pregnancy BMI was 23 and her weight gain has been appropriate. Blood pressure is a little on the higher end right now. Fundal height is 22 centimeters. Fundal heart tones are heard. Right, so these are all now reassuring things that we want to see. Ultrasound reveals head circumference, abdominal circumference, and abdominal weight at the 4th percentile. That's terrible, right? That means that the head circumference, the abdominal circumference, and the weight of the baby are below the 10th percentile. Too tiny, very small. Normal amniotic fluid level and fundal placenta are present. A biophysical profile is 8 out of 8, which is good. Umbilical artery Dopplers are normal. What is the most likely cause of the fetal findings? Right, so why is the baby tiny compared to its age? So the answer here was just fetal chromosome abnormality, which the reason you would pick this answer choice and even consider this answer choice is because they spent a little bit of extra time here telling you this sentence. On NBME, this would not be a sentence. Keep in mind that I've mentioned a couple times already that NBME questions are nothing like UWorld questions, nor are they anything like Step 1 questions. But there's a reason NBME questions are so good at testing how well you know your stuff. NBME questions would not tell you a lot of the extra shit that UWorld questions lay out for you, right? UWorld questions lay out everything for you, a little too much, so much that they're actually pointing you towards the correct answer choice. So not doing well on UWorld is obviously a very big indication that you're not ready for the step. And then not doing well on NBME tells you that you're not able to pull out data just from minimum information in the question, right? Because here they're giving you maximum information, so you should definitely get the question right. And then in NBME, they're giving you minimum information. information. So it's a little harder to get the question right, but if you do, that shows that you knew how to think. You knew how to follow the problem in the question. You knew what to evaluate, what to consider, stuff like that. They shouldn't have really told you this sentence, but they did, and that was actually the main hint for figuring out the correct answer choice. The other answer choices that some of these people in UWorld pick. Now, keep in mind these percentages of how many people answered correctly, answered incorrectly. You have to consider who makes these percentages. Like what students are actually part of the percentage. A few of the people taking UWorld are people that are doing it a second time right before they're going to take their steps, so they're ready. Then there's the people that are brand new also, and they're also part of it. So the percentage of students that are making up correct and wrong answer choices are a mixture of ready students to brand new students as well. There should have been no reason to pick maternal hypertension or inaccurate pregnancy dating as an answer choice. Right? But 15 and 15 chose that. So 30% of people chose those answer choices. Maternal hypertension would cause intrauterine growth restriction, but not like this. Not like this. Right? That's not the point in this question, because the baby isn't really affected. Her blood pressure is 138/89, but that clearly isn't being told to you as a major issue in this question. It's not the focus of the question. Right? They told it to you, but is it really that bad? Not really. Remember that blood pressure is actually pretty unique to every person. There are people out there for who 138/89 would be their completely normal blood pressure. That's how it always is. It's not really a problem for them, and they're okay. Now, of course, that might not be the case scenario here, but this is clearly not a question about preeclampsia or anything like that, right? Because if that blood pressure was a problem, then some of the other things following that later on would have been a problem. But everything is okay. Fetal heart tones are good. The fundal height is good. They have normal amniotic fluid. Biophysical profile is good. So the blood pressure is not really causing a problem at all. And then inaccurate pregnancy dating, that was impossible as an answer choice because they've dated the pregnancy with an ultrasound, which is the most accurate way to date a pregnancy. Right? So those two didn't make sense. Fetal chromosome abnormality was an answer choice here. The baby must be small because of possibly like Down syndrome or something. So let's take a look at what's happening here. They're going to say that the above. Oh, so this table up here was given, and fetal growth restriction is an ultrasound estimated fetal weight less than the 10th percentile for gestational age. Fetal growth restriction can be symmetric or asymmetric, and symmetric is global proportionate growth that lags. Growth lag that affects fetal organs uniformly and begins during the first trimester. Causes include fetal chromosome anomalies and first trimester congenital infections. In asymmetric fetal growth restriction, abdominal growth restriction is more pronounced than growth restriction of the head as a result of fetal adaptation to chronic inadequate uteroplacental perfusion and chronic fetal hypoxia. So the growth is not going to be very symmetric at all in that case scenario, because some of the parts of the baby are going to try to adapt to this issue that is causing growth restriction. Fetal redistribution of flow to vital organs like the brain, heart, and placenta occurs at the expense of less vital organs, leading to head sparing fetal growth restriction. So the head circumference would be at the correct percentile, but the rest of the circumferences are not going to be good, right? Because if the growth restriction is due to a lack of resources, then you distribute the resources to the most vital parts, which are obviously the brain and the heart. Her baby is universally, like globally, tiny everywhere. The measurements that they did everywhere, the head, the abdominal, and the growth weight were all small. Everything was 4th percentile. So that's symmetric intrauterine growth restriction. So if you look at the table now, symmetric things include chromosome abnormalities and congenital infection. Asymmetric things include things that would cause a lack of resources, like uteroplacental insufficiency, which we saw earlier would have the late decelerations, right? And then maternal malnutrition. Okay, so you can see global growth lag versus head sparing growth lag. And management is just weekly biophysical profiles, serial umbilical artery Doppler sonography, and serial growth ultrasounds to keep watching how the growth is going. And treatment would require to just go ahead and deliver as soon as you can. And delivery should occur before something non-reassuring starts occurring. Next question here, fetal macrosomia. So now it's the other side, the opposite thing. We just looked at growth restriction, things were tiny. Now we're looking at a big baby. So birth weight more than the 95th percentile, which 100% of the time on step is due to gestational diabetes, right? Because diabetes, as we looked at earlier, was a case scenario where the mom was very careless, didn't really manage her sugar intake very well, and then all that sugar is also going to make it to the baby, but the insulin that the mom is making does not make it to the baby. So the baby has to make its own insulin, and that causes the baby to now have an anabolic insulin surge that causes the baby to grow bigger and bigger. And then when the baby is born, keep in mind that the baby will be hypoglycemic because the baby was only hyperglycemic inside the mom because the mom had all the sugar. But after being born, the baby is just going to have a lot of insulin and no sugar. Right? So all that insulin is going to make the baby very hypoglycemic, which could be fatal. Hypoglycemia is fatal even in fully grown adults. So, the baby is going to be born hypoglycemic, and you have to keep in mind to give the baby some sugar because there's no other treatment you can give. The easiest thing to manage for hypoglycemia is just give the sugar, right? And then slowly make sure the baby recovers from this high insulin issue that the baby is having. So that's usually going to be a big issue there. Now, we also saw when we did gestational diabetes that when the baby is this big, the best thing to do is to just do a C-section rather than trying to get it out vaginally because you're going to have shoulder dystocia, you're going to break some kind of bone, clavicle break. You can also have damage to the brachial plexus. So a lot of issues can occur if you try to deliver a big baby vaginally. Diagnosis, of course, first things first, ultrasound, look at how big the baby is. Most accurate test is weigh the newborn at birth. Planned C-section delivery may be considered for an estimated fetal weight of more than 5,000 grams in women without diabetes and for an estimated fetal weight of more than 4,500 grams in women with diabetes. Because the women with diabetes are going to have a baby that are kind of bigger in a different kind of way. So the growth usually occurs in like the upper body areas, and the upper body areas, of course, is something that can be really problematic. See, legs are nice and linear. So when you're pulling the baby out, the legs come out very easily. There's nothing that's going to get stuck. But the shoulders are at like 90-degree angles, right? The arms are at 90-degree angles. So now when you're pulling the baby out and the head comes out super easy, then the shoulder becomes a problem. You have to do all this twisting motion to try to make sure you don't mess up any clavicular bones. These can break or dislocate the shoulder or pull the shoulder in such a way that you break the brachial plexus, right? Because most of these are going to lead to lifelong deficits. So you want to keep a lower threshold in diabetic moms because those babies, even at the 4,500 gram range, those babies are going to have a little more mass in the shoulder and chest area, the neck and shoulder and chest area. So complications, of course, as we said, right? Increased shoulder dystocia, brachial plexus injury, or Duchenne palsy as birth weight increases. I think that's all they talk about that. Yeah, so there's not much else over there. Two very specific questions here regarding some of the things we're going to be looking at soon. Ovarian hyperstimulation syndrome, and then, of course, ROGAM, right? Which ROGAM is the medication for preventing the RHD attack from the mom to the baby. So let's take a look at what's happening here. 28-year-old woman comes to the emergency department due to nausea, vomiting, and abdominal pain. For the past 2 days, she has had increasing abdominal pain and distension, which are now severe and causing persistent vomiting. So 28-year-old, right, she's not really pregnant or anything, but nausea, vomiting, and abdominal pain. So we know that when it was a really young girl, like in yesterday's questions about ectopic pregnancy, that anyone really young coming in with vomiting and abdominal pain was a sign that maybe they are pregnant and it could be an ectopic pregnancy. But this is not a young woman, so ectopic pregnancy might still be an S choice here. Be very careful not to pick that, right? There should be something in the question that gives away what's happening. For the past 2 days, she's had increasing abdominal pain, and now she's got persistent vomiting, right? She had an episode of watery diarrhea, but has had no fevers, chills, or sick contacts. She has no chronic medical conditions. She has been undergoing ovulation induction for infertility treatment. So, ovulation induction. Now, if you don't know how ovulation induction works, then this infertility treatment sentence right here doesn't really give you much information. But at the very minimum, it should make some sense to you that obviously there must be a play of hormones with progesterone and estrogen to make ovulation occur, right? So it's basically inducing the beginning of ovulation. So we know from back in step 1 that there was an LH surge, there was a lot of progesterone, things like that to cause ovulation. So they must be inducing that in her. So we're going to keep ovulation induction highlighted. Her last HCG injection was 7 days ago, and her last menstrual period was 3 weeks ago. Blood pressure is on the lower end, pulse is high, BMI is 21, which is great. Cardiac exam reveals signs of tachycardia. So her heart rate is clearly up, 104. The lungs have decreased breath sounds in bilateral basis, so that's not good. So we're going to highlight that. Lungs have decreased breath sounds. The abdomen is distended and has tympany, but no rebound or guarding. Right? So abdominal tympany. So tympany occurs because there's a lot of air. Right? Then air is what when you check tympany, you would kind of do like a knocking on the belly, and air is what helps vibrations of sound waves travel. So that's why you hear tympany. So for some reason, there's air in the abdomen. Now, lab results pretty normal. Pelvic ultrasounds reveal a small uterus with a thin endometrium, bilateral enlarged ovaries with multiple cysts, and large amount of free fluid within the abdomen. Which, again, the other thing that causes tympany is the free fluid. And so that's also something that can cause free fluid or cause tympany. So you have to consider what it was based off of the rest of the presentation of the baby, of the patient. And then they just ask you what's the most likely diagnosis in her. Now, of all the answer choices you would see here, looking at this kind of a case scenario where we're talking about ovulation induction and pelvic ultrasound is revealing that she now has bilaterally enlarged ovaries, then this issue of bilaterally enlarged ovaries must have occurred in relation to the ovulation induction, right? Because we just talked about it, that even if you don't completely understand how ovulation induction works, you know that ovulation back in step one, the number one thing to remember was the LH surge, and that you're doing things that would turn on the ovaries to cause ovulation. So now if she has bilaterally enlarged ovaries, the issue must have been because of whatever induction you were doing. So the best answer choice to pick, regardless of whatever other answer choices there might have been there, 100% of people should have gotten ovarian hyperstimulation syndrome as the S choice. It's very clear in the question. Like, what else would cause this? Right? She doesn't have any other conditions. They didn't tell you she has any conditions. Right? In another case scenario where something similar could present would be a person with what was that disease? Man, the end of Ramadan. Really killing me. That should be right here. PCOS, right? Polycystic ovarian syndrome, because clearly they're saying, they see multiple cysts as well. But PCOS women, right, don't present like this. First of all, PCOS women, most of them have a higher BMI, and PCOS women would have other issues related to the PCOS. And they would have PCOS before you would even do this. You don't really need ovulation induction in PCOS patients. You need to stop them from ovulating because their eggs are kind of not really doing too well, right? So the whole case scenario is completely different here. She has OHSS, ovarian hyperstimulation syndrome, a rare, very rare, in fact it's extremely rare, but of course on step one nothing is rare, a rare but life-threatening complication of ovulation induction. Ovulation triggers agents like ovulation trigger agents like ACG induction stimulate artificial maturation of multiple ovarian follicles in patients undergoing infertility treatment and can cause an exaggerated ovarian response, leading to bilateral enlarged cystic ovaries with multiple follicles, as well as overexpression of vascular endothelial growth factor, causing increased vascular permeability and capillary leakage. This is actually something people do to have multiple gestations, right? So if you've ever heard of some of those famous women who gave birth to maybe 11 to 12 kids at the same time, that was most likely done unnaturally with ACG injections. This causes massive extravascular fluid shifts, third spacing, and VEGF leakage into the intraperitoneal cavity, leading to ascites and abdominal distension. Affected patients typically develop OHSS 1 to 2 weeks after ovulation induction. Symptoms include nausea, vomiting, and abdominal pain. Other features include pleural effusions and intravascular volume depletion due to third spacing, which in severe cases can result in thromboembolism, renal failure, and death. Right? All in all, pretty easy question. Even though you may not have really known the concept of what's happening, it was very obvious that whatever hormones we're giving her have overactivated things. That's it. Right? Because the only other scenario where you would have multiple cysts in your ovaries would be the disease that's literally named after multiple cysts in your ovaries, polycystic ovarian syndrome. which has its own entire list of things that you have to know very well. Right? In fact, this page right here tells you everything you need to know about PCOS. Right? And then the two things that get tested, clomiphene and the progestin challenge test, which will be something that will be in the question. They'll describe doing the progestin challenge test, which as soon as they start giving progesterone, there's a bleeding that occurs, and that is a sign that they have PCOS. And then they give you a question with up and down arrows, and these are the things that are high: insulin, LH, and estrogen. And these are the things that are low: sex hormone binding globulin, FSH, and progesterone. Next question here. This one is going to be something we're going to be looking at pretty soon right now. 24-year-old pregravido, first pregnancy, comes to the emergency department for evaluation of pelvic pain that began a week ago as mild cramping, but is now constant and severe. So, cramping. I mean, it's pretty normal in pregnancy. I don't see anything severely bad, but the cramping is getting really bad, so we have to consider maybe something's wrong. She had a positive home pregnancy test 3 weeks ago and has also recently had some brown vaginal spotting. So that's concerning. And the vaginal spotting is concerning. There should be no spotting if you're pregnant. She has no chronic medical conditions or previous surgeries. Blood pressure is good. Pulse is on the higher end. The abdomen is tender and to palpation over the left lower quadrant, and rebound is present. So that's a little concerning. Right, so her again, cramping wouldn't be so bad of a problem if it wasn't severe cramping, because now it's obviously causing her a lot of distress. Pelvic ultrasound shows a small uterus with a thin endometrium, an 8-week fetal pole in the left adnexa with cardiac motion, and a large amount of free fluid in the pelvis. Laparoscopy confirms hemoperitoneum and a ruptured left fallopian tube. A left self-injectomy is subsequently performed. So a ruptured left fallopian tube. Very weird, right? Why would that happen? And they did a self-injectomy to fix that. On post-operative day 1, she's doing better in terms of vitals. Repeat labs show that I definitely incorrectly wrote how much her hemoglobin was supposed to be. I doubt it was 1. But hemoglobin was something, and then beta HCG of 12,987. So she's still pregnant. What is the best next step in her management? And they said to give anti-D immunoglobulins, which 60% of people picked. However, 25% of people picked the notorious answer choice of no additional management indicated. See, STEP really loves testing you on when it is appropriate to not do any additional management, because in America, where we order all kinds of tests, it is unfortunately also common to order a little excessively. Right? Oftentimes in America, you will order tests for your patients that you really didn't need to. That's actually harassment of the patient in a sense, because now you got to make the patient go do all these tests. They have to go to all these appointments. They might even have to pay if their insurance doesn't cover it. So it's very important to know where you don't need to do additional management. She needs additional management, and it was a very simple, straightforward thing of giving anti-D immunoglobulin, which is Rogan. So RHD alloimmunization occurs when RHD negative moms develop anti-D antibodies due to pregnancy with an RHD positive fetus, which usually occurs because the dad must have been RHD positive. Although most cases of RHD alloimmunization are associated with delivery of an RHD positive infant, alloimmunization can occur whenever there is significant fetal maternal blood mixing, such as in this patient with a ruptured ectopic pregnancy, which is why she had her left fallopian tube rupture. Right? Her pregnancy was ectopic. It was not a successful pregnancy. This is why she's presenting with symptoms that look a lot like appendicitis, right? With the rebound, a lot of cramping on one side, right? That's indicative of course, her not having appendicitis, but the fact that she must have had an ectopic pregnancy. It should have been very clear to you as you read the question. So ectopic pregnancies, of course, the baby doesn't really have that much blood per se, but there's enough for the mom to realize that there's something there that's not yours, and then the mom can make antibodies against RHD. And since the blood mixing has already occurred, she's going to have that immune response. Hence, all women with bleeding in pregnancy require maternal blood typing, and if they are RHD negative and have a negative antibody screen, a negative Coombs test, such as her, give anti-D immunoglobulin because the fetal blood type is typically unknown and possibly RHD positive. On your test, you're going to get an answer choice that says check for the baby's Rh status. That is not the correct answer choice. How are you going to check the baby's Rh? You can't really take the baby's blood, right? It's not something you can do, especially depending on how old the baby is. How old is the fetus, right? You can't really check the Rh status of the fetal blood. There's no way to get access to it. If you do anything, if you insert a needle through the mom to enter the baby, take blood out of the baby, then you pull the needle out, the blood is still going to leak out of the baby into the mom, which will then activate this Rh response, right? So there's no way for you to actually check the baby's Rh status. But you don't need to check it. It's not like Rogam is an extremely expensive medication or anything. So any mom who's Rh negative, you just give Rogam, right? Because just in case the baby is Rh positive, you don't want the mom to be attacking the baby, right? That's going to cause hemolytic disease in the newborn, possibly even kill the baby, right? So that's something that you have to understand. We're going to see that pretty soon in our next page. Immediate next topic here are polyhydramnios and oligohydramnios, and then we have the Rh isoimmunization. So since we just did a question on it, let's look at the Rh isoimmunization. Fetal red blood cells leak into the maternal circulation, and maternal anti-Rh IgG antibodies form that can cross the placenta, leading to hemolysis of fetal Rh red blood cells. Erythroblastosis fetalis occurs only in Rh negative women, and there's increased risk with previous SAB or TAB or previous delivery with no Rogam given. So usually we really only care about the whole Rogam thing on the second pregnancy, right? Because with the first pregnancy, the mom will, if assuming everything goes right, the mom will never be exposed to any blood from the baby until the day of the delivery, where the placental rupture or detachment will occur, and there will be some blood in that placental detachment that will be blood coming back from the baby to the mom, right? So that blood gets mixed with the mom now. So for the first time, the mom gets exposed to the baby's blood, but it's right when the baby is being delivered. So that first baby is safe. But now the mom has seen this new Rh thing. The mom is going to make anti-Rh antibodies. In her next pregnancy, if that baby is Rh positive, she'll kill it, right? So that's what happens. And that's why almost all questions about Rh stuff, you really only care if it's not the first pregnancy. However, if it is the first pregnancy, it's usually because it's an abnormal pregnancy, like our question right now, where it was an ectopic pregnancy, right? So the mom got exposed to the blood from the baby a little earlier than you would expect. Normally, there would be never any exposure from the baby's blood and the mom's blood. There's never any really combination there. Remember that the only way babies get their supply is through the umbilical area and the placenta, where maternal blood and fetal blood are crossing by each other, and fetal blood has a stronger hemoglobin, right? Fetal hemoglobin that can take oxygen off of the maternal hemoglobin. It's not that the mother's blood goes into the baby or vice versa. The blood is never actually mixing, right? Sensitized Rh negative moms with titers more than 1 to 16 ratio should be closely monitored with serial ultrasonograms and amniocentesis for evidence of fetal hemolysis. In severe cases, initiate preterm delivery when the fetal lungs are mature. To help the fetal lungs get mature, you can give, as we saw, betamethasone. Before delivery, intrauterine blood transfusions can be given to correct a low fetal hematocrit. So here they're going to show you now. You have the maternal Rh negative red blood cell. The mom doesn't have Rh. Then the baby is one with Rh. During delivery, so you can see it's not a tiny fetus, it's a baby that's pretty much ready to be born. So during delivery, right, when this is going to finally detach from the mom, and you're going to cut off the umbilical cord, there's going to be some blood from the baby that may have now leaked into the mom. So the mom is now sensitized to the fetal Rh plus red blood cells. So now you can see after delivering the baby, the mom is now carrying Rh antibodies. So now the second time she gets pregnant, if the baby is Rh positive, she can kill it. Right, so you can see how the first baby was perfectly safe. Right? Never really an issue. The first pregnancy equips the mom. The first pregnancy is equipping the mom. The second pregnancy, the mom can actually attack. Right? So that's what they're showing here. If the mom is Rh negative and the father is Rh positive or unknown, give Rogam at 28 weeks gestation. All you really need to know is that the mom is Rh negative. That's all you need to know. If the mom is Rh negative, you have to give Rogam. If the mom is Rh positive, then the mom herself has Rh, so she's never going to make antibodies against Rh, right? So for her, the baby having Rh positivity is not going to be anything out of the ordinary or anything weird for her. If the baby is Rh positive, give the mom RhoGAM postpartum as well. The dose is based on the Klein-Hauer-Betke test, which you don't really need to know about. Let me actually show you what it looks like. Like, you've probably never really heard of the Klein-Hauer-Betke test. I always forget it exists as a test until I finally come to this page. But really, it's just this kind of thing. So right here, let's put it right there. So what you're seeing is just the number. It's like a ratio of how many cells there are. So you have your bright pink fetal cells and maternal ghost cells, and the ratio of the two is what determines the dose of the RhoGAM. That's all that's happening. Right? So this is something that you don't really need to know about very well at all. If you look at it in reality under a real microscopic image, so this is an image from Wikipedia. So you can see the same thing again, right? Before we looked at a cartoon, now we can see the real ones, the real fetal pink cells, and then the ghost cells are all these white cells in the back. And so if we go on Wikipedia real quick, they tell you this is a test, or it's also called an acid elution test. It's a blood test used to measure the amount of fetal hemoglobin transferred from a fetus to a mom. Right, so this is blood mixing from the fetus to the mom. It is usually performed on Rh negative moms to determine the required dose of RhoGAM, Rho-D immunoglobulin, to inhibit formation of Rh antibodies in the mom and to prevent Rh disease in future Rh positive kids. So this is all they're doing. So if they ever give you something like this where you're seeing a bunch of red blood cells that look like ghost red blood cells, and then a bunch of red blood cells that are nice and pink, right? That's fetal red blood cell mixing into the mom. So if there's a lot of fetal red blood cell mixing into the mom, you have to give a significantly higher RhoGAM dose. Right? If there's not a lot, then you give a weaker dose. And that's all it really is. Nothing much more to that. Give RhoGAM to Rh negative moms who undergo abortion also, such as the ectopic pregnancy question we just did, or who have an ectopic pregnancy, amniocentesis, vaginal bleeding, or placenta previa, placental abruption. Anything that's happening in the pregnancy that's not normal, especially anything that's happening in the pregnancy that's not normal and causes blood mixing from the baby and the mom, you need to give RhoGAM, right? Otherwise, the baby's already at distress. Assume it's one of these other things like placenta previa or placental abruption. The baby is already at distress. Now there's blood mixing, and now the mom is going to cause even more distress to the baby if she starts making antibodies that will kill the baby, right? So you always have to keep that in mind. And we haven't seen that in the questions we've done so far, right? Because the questions we've done so far were not about this topic. All the questions we did on placenta previa, placental abruption, they never mentioned giving RhoGAM. But you can get a question on placental abruption, and then they'll ask you what's the next best step. Depending on what scenario they laid out in the question, the next best step may be to give the mom RhoGAM to prevent the mom from killing the baby, because they probably already did everything else. Like in the question stem, they probably already did the checking for accelerations, checking for fetal tones, checking for all these things, making sure the baby's alive, and then they're probably like, we're now preparing to deliver the baby because we need to deliver it. What else should we do before delivery? And there might be a bunch of answer choices. There's a bunch of things you need to do before delivery. And even after you realize that there's been some blood mixing. As soon as you realize there's some blood mixing, you need to give RhoGAM. And if you're planning to deliver early, you need to give all the things that will help the baby mature as quick as possible. One of which we looked at was betamethasone for fetal lung maturity. Right? Follow beta-HCG closely and prevent pregnancy for 1 year. Hydros fetalis when fetal hemoglobin is less than 7 grams is a problem, and fetal hypoxia and acidosis, carnicterus, prematurity, and death can all occur, which would all get tested with the non-stress testing things that we looked at, or decelerations, whether it's early, late, or variable deceleration. These are all things we saw with these topics, right? So those are some of the things that we looked at earlier. They are now going to be becoming a real issue that you would actually be checking for in these complications. Now, one of the key things they just laid out in a very small, quick thing was this: prevent pregnancy for 1 year, right? This is pretty important. So you have to tell the mom, let's not try to get pregnant anymore for a year at least. And to prevent that pregnancy, you would give contraception, right? Check out this question. 38-year-old woman. So this is well over the 35 age that we worry about. 38-year-old woman, G1A1. So her first pregnancy ended in an abortion, right? comes to office for follow-up a week after suction curettage. She initially presented 7 weeks after her last menstrual period for an initial prenatal appointment. At that time, she had breast tenderness but no abdominal pain, nausea, or vaginal bleeding. During that visit, ultrasound revealed an empty gestational sac. Beta HCG was super high. She returned a week later and repeat ultrasound confirmed a missed abortion. Suction curettage was performed, and pathological specimen from the procedure indicated a diagnosis of hydatidiform mole. Today, she has minimal bleeding, but no pain, fever, chills, or abnormal vaginal discharge. Vitals are fine, weight is okay. Pelvic exam shows minimal dark red blood in the vaginal vault and no active bleeding. On bimanual exam, the uterus is small and non-tender. No adnexal masses are palpated. Beta HCG is becoming really low. Right, the level is 1412, so starting to go away, which means they've successfully taken everything out. What is the best next step in her management? And here it's related to this preventing pregnancy for 1 year thing. Contraception for at least 6 months was the answer choice here. So what happened here? Well, management of hydatidiform mole, which we're going to be seeing, that's the next topic. Right? As soon as you realize there's a missed abortion or hydatidiform mole, you do suction curettage. Then you monitor weekly beta HCG levels to make sure that the removal was successful, that you got everything out, that she's not pregnant anymore. Right? You keep monitoring it until it's undetectable, which here it's still detectable, but it's going away. That's good. That is very, very low now. 4 digits, eventually it'll be 3 digits, and then it'll be gone. Monthly beta HCG levels times 6 months. Beta HCG undetectable, surveillance complete, can attempt pregnancy. So for this case scenario, the reason you are doing contraception here is because you want to make sure, you don't want to let her get pregnant again, because if she gets pregnant again in the next 2 months, then her HCG levels are going to start going back up again, and that'll cover up any HCG that's there because of her hydatidiform mole that you may not have taken out all the way. Right? So that makes sense. So this is a different case scenario that we're going to be looking at when we get to gestational trophoblastic disease, that you don't want them to get pregnant again until you successfully confirm that the molar beta HCG is completely gone. Right? Once you've made sure that her HCG level is not pregnant levels anymore, it's pretty much zero, or whatever the normal amount is at a regular non-pregnant day, then you know that the molar clearance is successful, and now she's good to go to get pregnant again. Right? If beta HCG was detectable, then you still have to keep checking for more gestational trophoblastic neoplasia, and you need to get rid of anything else that might be there from that failed pregnancy. A complete hydatidiform mole is the result of abnormal fertilization of an empty ovum by either 2 sperm or one whose genome then duplicates. The resulting gestation contains hypertrophic and hydropic trophoblastic villi that cause a marked elevation in the beta HCG level. Hydatidiform mole is a premalignant disease that can develop into gestational trophoblastic neoplasia, such as choriocarcinoma. A beta HCG is secreted by all gestational trophoblastic disease and is therefore used as a marker for disease progression or remission. Now, if beta HCG is your marker for disease progression or remission, then you need to avoid anything else that can cause beta HCG to go up, such as pregnancy. Treatment involves uterine evacuation via suction curettage and surveillance for development of gestational trophoblastic neoplasia like the choriocarcinoma. After suction, beta HCG levels are followed weekly until undetectable. A plateau or increase in beta HCG is diagnostic of neoplasia, gestational neoplasia. Once the beta HCG level becomes undetectable, monthly monitoring levels continue for 6 months. During that time, a newly detectable beta HCG level is also diagnostic for gestational trophoblastic neoplasia. So there should be no other confounding factor for what else could cause newly detectable beta HCG, such as pregnancy. So she should not get pregnant. During the surveillance period, contraception is prescribed as pregnancy would make it hard to determine the significance of a rising beta HCG level, whether it's pregnancy related, which it obviously would be, or is her HCG level going up because she has gestational trophoblastic neoplasia. GTN rarely develops after 6 months. Right? 6 months after suction curettage for hydatidiform mole. Thus, after 6 months of undetectable beta HCG, patients who are interested can attempt contraception once again. Below is an ultrasound showing you a complete mole, where we see the things we learned about. Right? The complete mole has the snowstorm, Swiss cheese appearance, or many of the other things they talk about. So let's do gestational trophoblastic disease since we're here now. That would be this topic right here, right? The hydatidiform mole. Cystic swelling of chorionic villi and proliferation of chorionic epithelium. only trophoblasts, which is a step 1 topic. That's the step 1 answer choice, where they're going to want you to pick what's causing it. So of course it's trophoblast, not the syncytial trophoblast or anything else like that. Just trophoblast. You just pick that as an answer choice. Presents with vaginal bleeding, uterine enlargement more than expected, pelvic pressure pain, associated with ACG-mediated sequelae. ACG causes a lot of issues, as we learned. It mimics many things because it has a similar alpha segment to many of the other things. So you get early preeclampsia before 20 weeks, thecal lutein cyst, hyperemesis gravidarum, and hyperthyroidism, right? Because the alpha subunit mimics TSH as well. Treatment is just to do a DNC and methotrexate, and then continue monitoring ACG for 6 months while being on contraception. So you see how in step 1 they don't have a complete breakdown. So you just added more to it from CK. You now understand that you would monitor ACG for at least 6 months while also being under contraception, so you don't get pregnant, which makes sense. In fact, with a higher IQ, it's something you would assume that if you're monitoring ACG so that the mom doesn't have any of this left in her, then ACG should not go up from pregnancy, so you must be also keeping the mom on contraception. But it's not that commonsensical, so they should have definitely had that here. Now there's 2 types of moles, complete or partial. A complete mole has a normal karyotype, because it's like a normal complete human. Most commonly enucleated egg plus a single sperm, subsequently duplicates paternal DNA. Hydropic, so the egg doesn't have anything. The sperm brought the 23 chromosomes, and then after fusion with the egg, of course the systems that make a baby out of 2 cells realized that there aren't enough chromosomes, so they duplicated the paternal DNA to make 46 chromosomes. So that's why usually it'll just be 46XX, right? Because if you duplicate 46Y, you would get 46YY, which is not what's going to happen. So usually it's just going to be 46XX. It could be 46XY as well, because of course the egg, although enucleated, would still be indicative of what else is there. Maybe the X is still there, right? So stuff like that. It's a very interesting thing how this works. Histologically, something that they started talking about a lot more now is the hydropic villi. This is an answer choice that's often there. Hydropic means edematous, swollen cells that are degenerating, like in this picture. Hydropic villi, circumferential and diffuse trophoblastic proliferation, no fetal parts, no P57 protein, which is a step 1 topic. Normally high uterine size and extremely high ACG levels, which can lead to thecal lutein cysts, which are of course another problem. Imaging shows the honeycombing, cluster of grapes, snowstorms, cheese. They name it so many different ways. They can describe it in a billion different ways, but basically this is what you're going to see. Right? You can see that in this image over here as well. Right? So when you see that and you don't see fetal parts, then you know it's a complete mole. Risk of invasive mole 15 to 20%, so that is a problem. And risk of choriocarcinoma pretty significant. Right? Pretty significant. With the partial mole, you have 2 sperms in an egg that successfully fuse, so you get 69 related karyotypes. Right? That's not going to work out too well. Only some villi are hydropic. There's minimal trophoblastic proliferation. You actually see fetal parts, so partial parts, right? And P57 staining is positive. It's maternally expressed. So what happens here? The uterine size doesn't really get big. The ACG levels don't really tend to get up that much. And when you do ultrasound, it'll be diagnostic. You'll see the fetal parts. Right? You'll see fetal parts, but ACG is not increasing. So that's a abortion right there. You need to get all of that out. Risk of other things are not that bad here. So this is a little more easy to deal with, if anything. The partial mole, easier to deal with. The complete mole has a bigger problem because it can lead to choriocarcinoma, which is something that can occur even after normal deliveries. Right? So this is the gestational trophoblastic neoplasia that they're talking about. Rare, can develop during or after pregnancy in mother or the baby. Okay, so very key thing to understand here. This can occur after a normal delivery with everything being completely normal, and it can occur either to the mom or the baby or both. It can occur anywhere. Malignancy of trophoblastic tissue, hence why it's called a gestational trophoblastic neoplasia, cytotrophoblast or syncytial trophoblast. There's no chorionic villi present. There's a high frequency of bilateral multiple thecal lutein cysts as well. Presents with abnormal increase in ACG, shortness of breath, hemoptysis, which might be the key thing they'll give you in the question, and they don't really have to give you much else after that. Hematogenous spread to lungs leads to cannonball metastases, as you see. Right, so they're showing you these circular metastases everywhere. They're literally everywhere on both lungs. So that's the problem there. Treatment is methotrexate. You treat it as if it's like some kind of pregnancy that got missed. Right? Amboss had this x-ray, which looks a lot different from this one here, but you can see it in this one as well. Right? Multiple opacities in both lungs with one prominent lesion in the middle left lung. Right? So the big things are like that one there, right? But there's a difference here. In here, some of it is showing up as an opacity, right? So either way, what you're seeing in this is going to be a mom who's going to be presenting with hemoptysis soon after delivery. It hasn't been that long that she delivered, and now she's got hemoptysis. That's all you're watching out for. A mom that just gave birth a couple months ago, maybe a couple weeks ago, and now she's coughing up blood. That is choriocarcinoma, right? And a bunch of practice questions here for you to check out. You can pause the video when you watch it on YouTube and just take a look at it all. Make sure you can actually catch what's happening in all of these and see that these are all different kinds of trophoblastic disease and what topics are being brought up. All right. So coming back to here, presents with let's actually now we can look at it since we just did the question. A range of proliferative trophoblastic abnormalities that can be benign or malignant. Benign gestational trophoblastic disease includes complete or incomplete motor pregnancies, which you can just evacuate. Malignant gestational trophoblastic disease or molar pregnancy that can progress to malignant gestational trophoblastic disease, such as an invasive mole. So invasive mole we saw had a 10 to 15% chance here, or 15 to 20% chance in step 1 book, right? And then a choriocarcinoma, which 2 to 5% chance. Complications of malignant gestational trophoblastic disease include pulmonary or CNS metastases and trophoblastic pulmonary emboli. Presents with first trimester uterine bleeding, hyperemesis gravidarum, preeclampsia at less than 24 weeks, and uterine size greater than dates. Right now what they're talking about is the complete molar pregnancy. That's how that presents. Risk factors include extremes of age, too young or too old, and a diet deficient in folate or beta carotene. So folate comes from, of course, foliage, vegetables, and beta carotene kind of comes from carrots, if anything. Best initial test, pelvic exam may reveal enlarged ovaries, bilateral thecal lutein cysts are there now, so that's the answer choice you would pick, or expulsion of grape-like molar clusters into the vagina. Next best, most accurate test is to do an ultrasound, which will show you the snowstorm, Swiss cheese, or whatever they want to call it, with no gestational sac or fetus present. Labs will show too high of an ACG, significantly high. Chest x-ray may show you the lung metastases, as we saw, the cannonball metastases. And if you do DNC, you get the cluster of grapes tissue, the hydropic tissue. Best initial treatment is to just get it all out, DNC. And then follow with weekly beta ACG monitoring. Treat malignant disease with chemotherapy. Treat residual uterine disease with hysterectomy. Chemotherapy and irradiation are highly effective for metastases. Now here in the book, you can see they didn't teach you what that question right there was teaching you. And although you're following with weekly beta ACG, you want to keep following for 6 months while keeping the mom on contraception. I can't wait till my writing pad comes in so that I don't have to use the mouse to write this. It was 6 months. 6 months of contraception, very critical. Because why were we doing 6 months? Because after 6 months, getting choriocarcinoma is extremely rare. Right? So choriocarcinoma was the issue. That's what we needed to watch out for. This is what the genetics of molar pregnancy kind of looks like. Right? So there's usually an enucleated mom. So you can see 2 eggs, 2 sperms that are connecting in here, or the same sperm is duplicating. So you see how you get 23XX if the same sperm is duplicating, because sperm, it's very, very unlikely that you're going to get a 46YY. That's not what's really going to duplicate very well. For whatever reason, that's not what occurs. And then you could get 2 sperms that are 23X and 23Y that connected, and you get the XY. But you never get a YY. That's not going to occur. So that's not the answer choice you pick, all right? Or the egg could have its nucleus, but then 2 sperms successfully made it, so then you get a partial mole. 2 sperms don't ever actually successfully make it. It's extremely rare for that to occur because of the whole acrosomal entry, and then the corona radiata of the egg has a response that it does. As soon as one sperm makes it in, all gates close, so no more sperm can come in. So it's very, very highly unlikely that two sperm cells will simultaneously make it into the ovum at the same time. Extremely unlikely. Right. Going back to the top, we had the polyhydramnios and oligohydramnios, which are both step 1 topics that are pretty straightforward. Right? Too much amniotic fluid or not enough amniotic fluid, which we talked about earlier in one of our videos, not I think 2 videos ago, where the reason amniotic fluid was important is because the baby has to swallow it. Right? The baby has to swallow it so that everything can develop, mainly the lungs. So when you have polyhydramnios, right, an AFI or amniotic fluid index of more than 25 on ultrasonography may be present in normal pregnancies, but fetal chromosomal developmental abnormalities must be considered. Etiologies are maternal diabetes, multiple gestations, isoimmunization with the ROGAM thing, pulmonary abnormalities like cystic lung malformations, fetal GIT anomalies like duodenal atresia, tracheoesophageal fistula, and twin-twin transfusion syndrome, all of which are step 1 topics. Basically, there's only going to be 2 reasons you're going to have polyhydramnios. Either the mom is making too much or the baby is not swallowing it, right? And you can see that the mom will be making too much in maternal diabetes, multiple gestations, pulmonary abnormalities, and fetal GI. These 2 things, these are things where the baby is not swallowing it. The baby, for example, if you look at fetal GIT anomalies, a baby with a tracheoesophageal fistula cannot be swallowing the amniotic fluid. A baby with anencephaly cannot be swallowing the amniotic fluid, so you end up having too much, right? So there's only 2 real reasons you're going to have polyhydramnios, and the question will help guide you to what is causing the polyhydramnios. You just have to catch and pick and choose the correct things. History usually asymptomatic. Nothing really happens to the mom per se. Diagnosis, fundal height is going to be greater than expected because the fundal height is going to be really high due to all the amniotic fluid, not because the baby is developing. Evaluation includes ultrasonography for fetal anomalies, glucose tolerance test for diabetes, and an RA screen. You're just checking for all of these things. Planned C-section is etiology specific, right? You don't do a C-section just because that's something you can do. You do it because depending on what's causing it. For example, with multiple gestation, you might need to do the C-section and get both of the babies out if they're not going to make it, right? Multiple gestation and twin-twin transfusion syndrome kind of go together, and this was something that I discussed in step 1, so we'll go back and look at it. Treatment, planned C-section is etiology specific, and complications, preterm labor, fetal malpresentation, and cord prolapse. So now if we go back here, let me see where I talked about that. Twin-twin transfusion syndrome. Sounds like a physiology thing right here. Let's see that find here. So the twinning is one thing that you definitely want to make sure you go back and revise if you forgot how that worked, right? Whether or not monochorionic, monoamniotic, whatever. Those some things, with the scab mnemonic, if you forgot this thing, definitely go back and revise that today. Make sure you understand it. There's a couple practice questions right here to help you see how to get tested. And then the next thing they talk about is twin-twin transfusion syndrome regarding how everything is developing. Right? So twin-twin transfusion syndrome per se isn't really taught in step 1 book, but Amboss had a question on it, and this is a really nice picture showing you what's happening. So you can see this is a dichorionic, right? You have 2 different amniotic sacs, 1 placenta that's being shared, right? That's the issue here. So monochorionic, because one placenta, diamniotic, because you have 2 amniotic sacs, right? Very obvious in the picture. And each of the amniotic sacs has to have its own connection. So you can see the bigger baby has a very good connection with the placenta. The smaller baby has a very weak connection with the placenta. So this baby is taking more of the resources than the other baby. Right? A 2050 gram, 2050 gram female newborn and a 2850 gram female newborn are delivered at 37 weeks gestation to a 23-year-old G2P1 woman. So one is 800 grams smaller than the other. The mother had no prenatal care, so that's a very careless mom. Examination of the smaller newborn shows a flattened nose and left side clubfoot. So flattened nose and left side clubfoot. Why would that occur? Well, look at the amniotic fluid in this baby, right? You could see that the baby is being squished. What was the point of amniotic fluid? It was cushioning. It was cushioning. This baby has cushioning. Nothing is being squeezed. This baby's nose is getting squeezed right here. This baby's foot is getting squeezed right here. Everything's getting squeezed, right? That's why that occurs. The hematocrit concentration is 42% for the smaller newborn and 71% for the larger newborn. The pregnancy was most likely which of the following? Well, with twin-twin transfusion syndrome, it always has to be monochorionic and diamniotic, right? So this is again a twinning question that is very significant and definitely gets tested on CK, right? One placenta supplying two different amniotic sacs. That's the only way you can get twin-twin transfusion syndrome. If they had their own placentas, then there will be no sharing. So then twin-twin transfusion syndrome cannot occur. So when fetuses share one amniotic sac, there is no hydramnios. Right? When they share one, so that's another thing. If they have one placenta and one amniotic sac, then there's also going to be no real issue because there's, the amniotic fluid will be cushioning both of them successfully. All right. So that's something to keep in mind here, right? You want to go back and revise this, make sure you understand what the differences are, right? Two placenta, two amniotic sacs, one placenta, two amniotic sacs, one placenta, one large amniotic sac, kind of, cushioning both babies. And then any later with decleavage, any later by the 2-week point after 12 days, with really late cleavage, you can actually get this kind of a conjoined pregnancy, right? Super rare, but it occurs. Most commonly, it is this, right? One placenta, two amniotic sacs. That's the most common one. And when that occurs, you can get twin-twin transfusion syndrome, as you can see here. Right? So that's something that you can go ahead and make sure you go back and take a look at. This question here is for oligohydramnios, so let's take a look at oligohydramnios first. This is an amniotic fluid index less than 5 on ultrasonography. So this is, remember the amniotic fluid index was something you were checking for the biophysical profile thing. And okay. All right. So amniotic fluid index less than 5. So usually asymptomatic. Again, the mom doesn't really have any symptoms. But intrauterine growth restriction or fetal distress may be present because the fetus is not going to be having enough amniotic fluid to cushion it. Etiologies of fetal urinary tract abnormalities, where she can't make enough amniotic fluid, right? So, fetal urinary tract abnormalities, the baby is unable to actually use the amniotic fluid. There's nothing there. Right, so you get renal agenesis and GU obstruction, chronic uteroplacental insufficiency, where the mom's placenta or the umbilical cord is unable to supply the baby correctly, postterm pregnancy, and rupture of membranes. All of these are case scenarios where you just might not have enough amniotic fluid. The sum of the deepest amniotic fluid pocket in all 4 abdominal quadrants on ultrasonography should be more than 5. It'll be less than 5 here, so that's how you diagnose it. Rule out inaccurate gestational dates. Treat the underlying cause if possible. Usually it's not possible. And associated with a 40-fold increase in perinatal mortality. The baby usually doesn't make it. Other complications include musculoskeletal abnormalities because of the lack of cushioning. So you get the club foot and the facial distortion, as we just saw on the smaller baby in the twin-twin transfusion syndrome. Pulmonary hypoplasia because there was no amniotic fluid for the baby to swallow, so the lungs didn't develop. Umbilical cord compression because there's no cushioning. And intrauterine growth restriction, again because there's no cushioning and there isn't enough supply for the baby if the umbilical cord is compressed. Right? No nutrients are coming. So take a look at this question. 26-year-old, first pregnancy, 25 weeks gestation, comes due to preterm labor. For the last 6 hours, she has had intermittent painful contractions, but no vaginal bleeding or leakage of fluid. So she's getting painful contraction. Blood pressure is fine, pulse is fine, BMI is good, cardiopulmonary exam is normal, uterus is non-tender. On sterile speculum exam, the cervix is visibly 2 centimeters dilated. Fetal heart rate is good, 150, with no decelerations or accelerations and minimal variability. So now this is kind of weird. See, if the mom is having contractions, then there should be something, either a deceleration or more likely an acceleration due to distress, but nothing is happening. So the fetus isn't responding, right? Contractions occur every 2 to 3 minutes on dynamometry. She is administered indomethacin for tocolysis, right? So this should be the first thing you immediately thought of when you read this. Generally speaking, when you get a pregnant woman with painful contractions and it's not time to deliver yet, you try to stop the contractions. Indomethacin can do that. This intervention increases her risk for what? Well, if you stop the contractions, there's a high chance now that she can get oligohydramnios. And this is a great question because this clearly was not mentioned here. What was mentioned here, though, is this aspect of uh, rupture of membranes, right? Rupture of membranes. Now, anything that can lead to rupture of membranes. So you have to understand this happens throughout the book, right? They'll list out things that could cause, right? These are all etiologies that could cause the main problem, oligohydramnios. What you have to know are other things that could cause these things. Our question is on one of those other things, which is the indomethacin. Right, so this is what you have to understand when you're studying from first aid, because you need to combine questions to learn about this part. The book only teaches you that this thing, all of these etiologies can cause this disease. You need to figure out what are other things that can lead to these etiologies, such as in this question. She is in preterm labor. Management depends on gestational age, with increased intervention required at earlier gestations due to risk of neonatal prematurity. Patients at under 32 weeks gestation in preterm labor require indomethacin to inhibit the contractions and delay delivery. That's called tocolysis. Betamethasone. So now we're going to see the list of things we're supposed to get. Betamethasone for fetal lung maturity. Magnesium sulfate to decrease cerebral palsy is fetal neuroprotection. And penicillin to decrease the risk of GBS infection. These are the triad of medications you need to give every time someone is about to deliver a baby earlier than usual. And earlier than usual means literally like usual, like the post 37 weeks. So if it was before, like if it was actually after 32 weeks, you would still give these things depending on whether or not you're ready for the delivery. Betamethasone, magnesium sulfate, and penicillin are a must for any time you're delivering a baby before it's time to naturally deliver, right? Because you need the lung maturity, the cerebral maturity, the brain maturity, neural maturity, and to prevent GBS, which could cause neonatal sepsis and kill the baby, right? Because you're not going to have time to do everything. Of course, you'll check the mom for group B strep agalactiae infection, but it just doesn't hurt to give the penicillin. There's no problem with it, right? So those are all things that you have to keep in mind. You're going to learn this as we go on, but very important information, because you could get a question literally on fetal neuroprotection and they'll be like, what else should you give? And very few times will you actually want to pick magnesium sulfate, because we usually associate magnesium with preeclampsia, but that's not the only place it's used. It's also good for decreasing, or it's also good for fetal neuroprotection. So many benefits of magnesium. Although the benefits outweigh the risk, indomethacin can have adverse fetal effects. Indomethacin is a non-specific COX inhibitor. It inhibits both COX-1 and COX-2. Decreases prostaglandin production and leads to fetal vasoconstriction. So then you get a premature closure of the ductus arteriosus. Remember, indomethacin is to end the PDA, right? Patent ductus arteriosus, whereas prostaglandin would actually keep it going. And sometimes you need to keep it going because of various cardiac anomalies that may be there. The subsequent decreased renal perfusion and fetal oliguria can result in oligohydramnios, amniotic fluid index less than 5 centimeters, particularly with prolonged administration. So patients receiving indomethacin for less than 48 hours. This oligohydramnios is transient and resolves upon medication discontinuation. Risk of intraamniotic infusion. Oh, these are some other answers people pick. So 20% of people chose intraamniotic infection and 20% chose pulmonary edema. But those two answer choices really didn't make much sense for what's happening in this question, right? The only thing in this question was, what does indomethacin put her at risk for? Well, indomethacin is going to be ending a lot of the normal things that are supposed to be occurring in pregnancy. So it's not going to cause pulmonary edema, and it's not going to cause intraamniotic infection. Those things didn't really make sense. All right. So that's it for that. And then let me see where we are now. And then the next things are multiple gestation, and then we're done for this chapter. So multiple gestation, which was the twinning thing we were talking about, right? That you should go back and revise. So make sure you come back here, take a look at this. The scab mnemonic kind of did everything. It was perfect. Cleavage is 0 to 4 days. Nothing is shared. So share nothing. Separate chorion and amnion. Right, so separate. Everything is separate. You have your own placentas and 2 amniotic fluids. Cleavage 4 to 8 days, you share the chorion. Chorion is basically the placenta. Right, so you're sharing the placenta. There's only a chorion and amnion, so you know the amniotic fluid is the bag that you're inside. So it shouldn't be very confusing. Later on, 8 to 12 days, you have a shared amnion as well. Nothing separated. Shared placenta, shared amnion. And then if you keep going, even the bodies are shared now. Right? So that's kind of the quick summary of that. So you can see that here, various types of twin placentation. And then here is where you're seeing some things that can occur. Right? So when you have a shared placenta, you can get different kinds of problems. Here, there's a lambda sign for twins and a T sign for twins. These are some things that are more now CK topics. So what you're seeing in the lambda sign is they have 2 placentas. You can see there's a line here dividing the two. 2 placentas, so there's dichorionic, diamniotic. Each one gets its own blood supply. This is safe. There's nothing that can happen where you get twin-twin transfusion syndrome. Here though, where you're sharing the placenta, you can get twin-twin transfusion syndrome. Same source of resources, so one baby may overpower the other and take all the resources. Right? So affects 3% of all live births. Since 1980, the incidence of monozygotic twins has remained steady, whereas the incidence of dizygotic fraternal twins and higher order births has increased. Characterized by rapid uterine growth, excessive maternal weight gain, and palpation of 3 or more large fetal parts on Leopold maneuvers. Of course, what do? You do ultrasound. That's the answer for everything in pregnancy. You go in and you look and you're going to see it. Beta HCG, human placental lactogen, and MSAFP are also going to be higher than normal because you have double the number of babies. Treatment, multifetal reduction, and selective fetal termination is an option for higher order multiple pregnancies. See, what can happen is if you have too many, let's say you have 4 pregnancies at the same time, you may need to cause selective fetal termination. You may need to choose and kill at least 3 or 2 of them, and you would pick the ones that are developing the weakest, developing the least, so that the others can develop successfully. Right? That's kind of a concept here, so you have to make sure you understand that. This ultrasound here is showing you a molar pregnancy. Right? Transvaginal ultrasonogram shows a large complex intrauterine mass with cystic regions that have the characteristic appearance of grapes. Right? This is not as evident as this. So on STEP, don't expect a very evident image of the snowstorm. But you can kind of see the snowstorm. I mean, they're not supposed to be this many little holes here. Each of these are the hydropic villi. Okay? You don't really see a fetal pole. There's no fetal pole here. The baby isn't really developing. You just have a lot of tissue that you need to do now DNC and get it all out. Right? Moving on with the twinning thing. Antepartum fetal surveillance for intrauterine growth restriction and management by a high-risk specialist is recommended. You need to get a very good obstetrician to manage this pregnancy. Complications that can occur. Patients are 6 times more likely to be hospitalized with complications of pregnancy. Increased incidence of placenta previa and need for C-section delivery. So of course there's a high risk of placenta previa now because you have the chance of getting a wider placenta, or the chance of having 2 placenta. So now there's more chances that the placenta could be right where the cervix is, right? And that's obviously going to be a big problem because now if you have placenta previa, you can't do vaginal delivery. So you have to do C-section, which is a surgery which puts mom at a whole other list of risk factors. Right? So need for C-section delivery. Fetal complications are just the twin-twin transfusion syndrome, growth restriction, preterm labor, and more risk of congenital malformations because there may not be enough cushioning to cushion both babies, right? And all of these complications are significantly more problematic for any mom that wasn't getting perinatal checkups, any mom that wasn't regularly coming in for their pregnancy checkups. Okay, so that wraps that up. In the next video, we'll go into abnormal labor and delivery, which will get to see all the things that occur during delivery and where mistakes can occur.